Axillary brachial block is carried out with the patient in the supine position, with the arm abducted to 90 degrees, and with the forearm also flexed to 90 degrees. It is tempting to both the patient and the anesthesiologist to place the patient's hand under his head. However, this results in hyperabduction of the arm and obliterates the brachial artery pulse in 80 to 85% of normal adult patients. And since the pulse is the primary landmark with this technique, this position is counterproductive. The axillary arterial pulse is identified out where it is easy to locate and is followed proximally as far as possible, ideally to the point where the pulse disappears under the pectoralis major muscle. The higher the needle can be placed with this technique, the greater the chance that the tip of the needle will be above the level of the humeral head, which tends to obstruct the cephalad flow of the anesthetic solution. So with the index finger on the arterial pulse, as high in the axilla as possible, a 22 to 24 gauge short bevel needle attached to the syringe by a length of extension tubing is inserted just superior to the fingertip, directing the needle towards the apex of the axilla, such that the needle will be traveling in almost the same direction as the neurovascular bundle. The needle is advanced slowly until one of three endpoints indicates that the tip of the needle lies within the axillary perivascular space. If a short bevel needle is utilized, usually a fascial click will be felt as the tip of the needle penetrates the tough axillary sheath. Or, if the advancing needle encounters a nerve, a paresthesia will indicate that the sheath has been entered. Or, if bright red blood appears within the hub of the needle, the artery has been entered. So if the needle is simply advanced through the posterior arterial wall, then it must be in the sheath behind the artery. Regardless of endpoint, when the axillary sheath has been penetrated, following aspiration, an appropriate volume of local anesthetic is injected in small increments with repeated aspiration for blood in between. The needle should be withdrawn to the subcutaneous tissue to block the intercostobrachial and the medial brachial cutaneous nerves by depositing a few cc's of local anesthetic superficial to the arterial pulse. Following this subcutaneous injection, digital pressure should be maintained as the arm is brought down to the patient's side. This maneuver is important if the injection happens to be made below the level of the humeral head, as it removes the obstruction to central flow provided by the humeral head when the arm is abducted. In evaluating the distribution of anesthesia following an axillary perivascular brachial block, it is important to remember that the local anesthetic is being injected at the level of the terminal nerves. Therefore, the area blocked or missed will be in the distribution of peripheral nerves. If the volume is insufficient, the most commonly missed nerve is the musculocutaneous. And when this nerve is not blocked, anesthesia will be lacking in the distribution of the lateral antebrachial cutaneous nerve. In addition to the use of a large volume of local anesthetic, placement of the needle high in the axilla and the use of firm digital pressure behind it will increase the likelihood of the local anesthetic reaching the musculocutaneous nerve before it has left the sheath. In clinical practice, 20 cc's of local anesthetic is usually insufficient to reach the musculocutaneous nerve, whereas 40 cc's is usually sufficient to do so. When carrying out a block in critically ill patients, particularly those with cardiovascular disease, it may be necessary to use a low volume technique in order to minimize the possibility of adverse systemic effects from the local anesthetic. To do this, the axillary block is carried out as described, but injecting only 10 to 15 cc's into the sheath, with firm digital pressure applied just behind the needle. The needle is then withdrawn to the subcutaneous tissue, and with the fingers still on the artery, it is redirected into the substance of the coracobrachialis muscle, just superior to the axillary artery and sheath. 5 to 7 cc's of local anesthetic injected therein will readily block the musculocutaneous nerve within the substance of the coracobrachialis muscle, the fascia of which will confine the injected local anesthetic. The needle is then withdrawn to the subcutaneous tissue again, and several cc's are injected superficial to the axillary artery in order to block the intercostobrachial and the medial brachial cutaneous nerves. With this low-volume axillary perivascular technique, a total of 20 to 25 cc's are utilized for the entire anesthetic procedure.
Say stop, and I will stop.
The axillary perivascular technique of brachial plexus block is primarily utilized for surgery on the hand and forearm. However, when the subclavian perivascular and interscalene techniques are contraindicated, the axillary technique carried out with larger volumes injected through a needle placed high in the axilla with firm digital pressure behind it can provide anesthesia for surgery on the upper arm and even the shoulder. So at the beginning of this little session, we started out with the concept of finding a single space where, albeit in the periphery, the nerves are in an anatomical situation similar to that seen in the epidural or spinal canals. So that regardless of the technique we're choosing, by placing a needle within this fascia enclosed space, we can reduce brachial plexus block to a single needle stick followed by a single injection of local anesthetic that should provide a simpler technique of anesthesia than traditional techniques, should provide more reliability in terms of success, and perhaps most important, should minimize the possibility of complications by minimizing the number of needle sticks and injections. And certainly safety during the learning phase of a regional anesthetic technique is an important feature.